This is not a promotional marketing video. This video is intended for patients about to be admitted for surgery for serious gynecological conditions at Royal Surrey County Hospital. Your surgery may vary slightly and, if so, this will be outlined to you by the team when you are seen a few days prior to your surgery. At this appointment, your consent for surgery will be obtained and any of your wishes will be noted.
Hello, I'm Anil Taylor. I'm a consultant gynecologist and a cancer specialist with over 30 years of experience in the field. My expertise is in the surgical treatment of all gynecological cancers, including ovarian cancers. In this video, I would like to explain what is involved in surgery for advanced ovarian cancer. I know that a diagnosis of ovarian cancer can be very daunting, and preparing for surgery to treat it can be a big moment. I want to make sure that you feel as informed and as prepared as possible for your upcoming surgery. In this video, I'll walk you through the key aspects of the operation, what we aim to achieve, and the potential risks you should be aware of. The main aim of the surgery is to remove as much of the cancer as we can. This is called cytoreductive or debulking surgery. By reducing the cancer to the smallest volume possible, ideally no visible disease, we significantly improve the chances of your chemotherapy being more effective. This approach gives us the best opportunity to control the disease long term. Now, because ovarian cancer often spreads to nearby organs and tissues, this surgery can be very extensive. During the operation, we will remove your ovaries, fallopian tubes, the uterus and the cervix. We will also need to remove the omentum, which is a fatty apron inside your abdomen where ovarian cancer often spreads to. Additionally, we will also need to remove any visible cancer deposits on the peritoneum, which is the inside lining of your abdomen and covers all the organs, including bowel. In some cases, we may need to remove part of the bowel or the spleen or any other affected tissues, but these decisions are made during the surgery based on what we find. If you have bowel surgery, then depending on which segment of the bowel has been removed, the rejoin that we make sometimes has to be rested in order to prevent any leakage of bowel contents in your abdomen. This can become very serious and life-threatening if it were to occur. In order to minimize this leakage, the joint sometimes has to be rested. To achieve this, we have to divert the flow of your bowels prior to this joint. We therefore sometimes have to make a stoma bag, which is in most cases is a temporary bag for a few months, but rarely it can be a permanent bag. However, please note that most patients having bowel surgery don't actually need a bag. The risk of ending up with a bag is probably less than 5%. Whether you require a bag is a decision we will only be able to make during your surgery. This will be a major procedure lasting several hours. It's natural to feel nervous, but I want to reassure you that you'll be in the hands of an experienced team who will be closely monitoring you throughout. Now, it's important to talk about the risks. As with any major surgery, there are immediate risks which you should be made aware of. These include bleeding, which might occasionally require a blood transfusion. There's also a risk of infection such as wound infection, urine infection, or chest infection. We take every precaution to minimize these risks, but they can still occur and can delay your recovery and can sometimes also delay your chemotherapy, which we would be keen to avoid. Another possibility is damage to surrounding organs. This can include injury to the bowel, bladder, ureter, diaphragm, spleen, pancreas, or blood vessels. If this happens, we'll address it immediately during the surgery, but once again, it may prolong your recovery. Another serious risk is that of forming blood clots in your legs, which could dislodge and travel to the lungs. This is very serious if it happens, as it can cause sudden death. We will be very keen to prevent this using special stockings and daily blood thinning injections for 4 weeks. You or a relative will be taught to administer these injections when you go home. However, the best method of preventing blood clots is by becoming mobile at an early stage and getting you out of your bed. We will therefore be very keen to get you up and into a chair on the very next day. We will be encouraging you to take a few steps around your bed and around the ward. This will be uncomfortable initially, but you must give us your full cooperation to achieve this and prevent blood clots. Cancer surgery, pelvic surgery, long surgery are all strong risk factors for developing blood clots. That is why it is so crucial that you help us by becoming mobile quickly. After surgery, you will spend a few days in the hospital. The first couple of days may be uncomfortable, but our team will manage your pain carefully and support you as you begin to move around and start eating again. You may spend these initial 48 hours in a high dependency area with close nursing observations. We will then get you to the general ward for further recovery and eventually try to get you home by about day 5. Your subsequent recovery at home will take a few more weeks, but will be with you every step of the way. All the specimens that we remove from your body will be processed in the lab, and this result will be available within 2 to 3 weeks. When you are admitted just prior to the operation, you will get a chance to meet the anaesthetist. They will discuss your pain relief options after the surgery. Broadly speaking, there are 2 main options that you should consider. One is an epidural, which stays in for the next 2 to 3 days, providing you with pain relief. The other option is that of having wound catheters placed at the end of surgery whilst you're still asleep. These catheters slowly trickle in a small amount of local anesthetic in the wound and can also give you pain relief for the next 2 to 3 days. Whilst epidurals can give you deeper pain relief, they can also affect your blood pressure and can also slow your mobilization and your discharge from the high dependency area. For that reason, I much prefer my patients to have wound catheters rather than epidurals, unless there are other very good reasons for having an epidural, which the anaesthetist will explain. These wound catheters can also provide good pain relief. In the 24 hours prior to your admission or just prior to your operation, you will also be given a strong laxative or an enema to clear your bowels. This is in case you require bowel surgery. I know this has been a lot to take in, but please don't hesitate to ask any questions. My goal is to make sure you feel confident and supported as we move forward together. Amongst our team, there are dedicated senior specialist nurses who will introduce themselves to you and will be in constant touch with you immediately following your discharge from hospital. They will help you troubleshoot any problems that you may be encountering after your discharge. If you are having surgery under my care, then you will have an opportunity to meet me in person a few days prior to the operation. You can ask me any questions at that time. At this appointment, you may be asked to sign a consent form going over all that I've just mentioned in this video. Finally, I would like to assure you again that you will be looked after by a dedicated team of experts who will try and get you back on your road to recovery. I shall look forward to meeting you in the near future. Thank you.